Okay, perfect. Hi, everybody. Welcome to the Childhood Cancer and the Environment Program webinar series. I'm Hannah Thompson from Mount Sinai. I'm one of the members of this group, and I'm very excited for this webinar series and this last webinar of the academic year. Today we have a really dynamic presentation from Dr. Omar Shakil and Dr. Nikki Wood, the role of environmental health in pediatric oncology clinical practice. So I just wanted to briefly introduce them and then let them get started. So Dr. Shakil is an assistant professor and board certified pediatric hematologist oncologist in the Department of Pediatrics, Division of Hematology Oncology at Baylor College of Medicine and provides clinical care at Texas Children's Hospital. He is currently the lead physician in the long-term survivor clinic at Texas Children's Hematology and Cancer Center, and serves on the Scientific Advisory Council for the Childhood Cancer Prevention Consortium. He's a member of the Childhood Cancer and the Environment Program, and his clinical expertise and research focus are on integrating environmental health into clinical pediatric cancer care and improving long-term outcomes. And Dr. Nikki Wood is a board certified pediatric hematologist, oncologist, and clinical informaticist at Children's Mercy, Kansas City, and an associate professor of pediatrics at the University of Missouri, Kansas City. She co-directs the Cancer Predisposition Clinic at Children's Mercy, where she focuses on the care of children and families with inherited cancer risk, including surveillance and prevention strategies. She's a PACU champion for the Childhood Cancer and the Environment Program. So I am so grateful that you guys are joining us today, and we're really looking forward to your presentation. I'm going to stop sharing now and pass it off to you.
Thank you. Let me share and get my slides pulled up here. Okay. Are you able to see that, Hannah?
Yes, I see your slides.
Okay, perfect. Thank you. All right. We ready to get rolling then, I assume? Okay. This webinar series has done an excellent job walking through the epidemiology linking childhood cancer and environmental exposures. And many of the topics we'll touch on today have actually already been discussed from that population level perspective, or at least some of them. And so today we're going to take a different lens, and it's going to be the clinical one. And we're going to focus on what this looks like in real life, the questions that parents are asking, the moments these concerns come up in care, and how we as clinicians respond when families are searching for answers. So thank you, Hannah, for doing those introductions. So I will skip past us introducing ourselves, but I did want to briefly highlight for those that might be new to CSEP for the Childhood Cancer in the Environment Program that this was a program that was created to support the PACUs in responding to the questions that families and clinicians are asking about environmental chemicals and the childhood cancer risk in association with those. So our focus is on clinical education and patient-centered risk reduction strategies with the goal of helping families feel supported as they navigate difficult questions about why cancer occurs and what can be done moving forward. Slides one, I think. There they go. So there's two important trends that I want to highlight. From 2010 to 2022, the incidence of childhood cancer has been steadily increasing. At the same time, the survival rates have improved dramatically, reflecting what major advances, right, in cancer treatment. So we're doing much better at treating childhood cancer, but more children are being diagnosed. That divergence raises an important question. If treatments are improving, why is the incidence rising? This tension is really what motivates that need that we have to look beyond treatment alone and consider other contributing factors, including the environment, genetic, and other influences. Incidence trends by cancer type, including several of the most common childhood cancers, leukemia, brain tumors, non-Hodgkin's lymphoma, bone cancers. We're seeing increasing trends in these, and most of them are statistically meaningful. This isn't random year-to-year variation. It really represents a consistent and measurable pattern over time. And this data comes from a good source, the National Childhood Cancer Registry and the SEER, which gives us confidence that what we're seeing is real. And this trend pushes us to ask deeper questions about what factors, including environmental exposures, like I said, may be contributing. I wanted to highlight why environmental health belongs in pediatric oncology. Childhood cancer incidence, as you saw, is rising, and families are asking some version of the same question: why did this happen to my child? At the same time, many clinicians feel unprepared to address environmental exposure questions despite growing evidence that these factors matter. And that gap creates a clinical imperative. This isn't just about data, it's about real conversations happening at the bedside. Environmental health needs to be part of how we practice, not because we always have definitive answers. Spoiler alert, we don't, but because families are looking for guidance and support. So these questions, they're already in our clinics. The question is, how prepared are we to meet them? To better understand these perspectives from clinicians, we distributed surveys at both of our institutions, and those results closely mirrored a similar survey that was conducted about a decade earlier, and that was actually reassuring. Clinicians are highly aware that environmental factors may influence childhood cancer risk, and families are asking these questions regularly. The disconnect is comfort. Most clinicians don't feel adequately prepared to respond. And importantly, this isn't resistance or lack of interest. There's really a strong openness to support this work and the structured tools that have been and are being developed by this work. And that tells us that this is a solvable problem, and it reinforces the need for practical frameworks and resources that help clinicians engage in these conversations with confidence. So we're getting around trying to spread the word. We've had a lot of great opportunities. We've done a lot of grand round style and other style presentations at major institutions across the country, into national organizations like ASPO, the National Association for Genetic Counselors, and Advanced Practice Providers in HEMONC national groups. We started early with this work in 2023, starting with workshops, and we did a deep dive workshop, multi-day workshop up in Racine, Wisconsin, with advanced practice providers and trainees, and that included 50 participants from about 14 different states. And we surveyed those folks about 3 months after the workshop, and it was great to hear that 86 of them said that their perceptions regarding environmental risks and childhood cancer had actually changed because of the workshop. 80% of them said that they had made changes in their clinical practice, and over 50% had shared the material with colleagues and other folks and families. So that was really reassuring. We've done smaller one-day workshops at other institutions, both mine and Dr. Shaquille's. Emory was a recent one, and then we did another multi-day workshop on Catalina Island, bringing in providers and clinicians from the Southern California area, which was a really great workshop. We're also doing some work products in the last year. We've had 4 peer-reviewed publications come out. We've also had a couple articles recently in Time magazine. And we're not stopping there. We're continuing to figure out, what's our next workshop, where's our next presentation, and more media is on the way and publications. We're working on engagement with the Children's Oncology Group. And I've also been working locally to get some of this work in the general pediatric space with some local groups that I have listed there. I am going to let Dr. Shaquille take over for a bit, and then I will circle back for some cases.
Yeah, thanks so much, Nikki, for that introduction. So I wanted to start off by saying at Texas Children's, we're building this environmental consult service. And the reason why I became interested, like Nikki, was a lot of these families asked me, why behind their cancer diagnosis during my training and beyond. And so together, through the Childhood Cancer Environment Program and the PACEs Nikki mentioned, we're building this service to help clinicians, patients, and families and caregivers better understand their environment. And the goal is to create a structured, realistic model to help families understand this and kind of reduce their risk moving forward. And so I wanted to talk us through our journey of the first ever consult service. So Nikki mentioned these workshops that we were doing. So at Texas Children's, we did our workshop in 2024, and we confirmed that clinical education for oncologists does not provide any sort of formal education or introductions to the contributions of environment in childhood cancer care. Um, After that, I conducted my own survey of oncologists, and Nikki briefly presented this. But the main takeaway was that most providers are not comfortable. I took this to our Family Advisory Council in 2020, in May of 2024, and wanted to get their feedback. And families were very excited about this. Some said we have other kids in the family we're worried about. Including environmental health would reduce our anxiety. So late in 2024, Nikki and I and epidemiologists, we made our environmental health history form. And in 2026, we submitted an IRB to administer this environmental health history intake or assessment form to our patients. And even now, next week, Nikki and I are meeting with the Children's Oncology Patient Advocacy Group. So I want to highlight this has been an iterative process. We are building this with clinicians and families, not just for them. And this is the basic workflow we are envisioning. And again, it focuses on the patient. A referral will come from a family concern or a provider during their routine care. And we screen them using our environmental health history tool, which I'll get into. From there, we are going to identify certain things that we're going to counsel them on and give them personalized recommendations on how to reduce their risk. And then we're going to be following up with them and supporting them. So this is central to our model, this environmental health history intake form. And this aligns with the Spain's planetary health model, which recognizes that a child's cancer risk and outcomes are connected to the environment they live in, from the air and water to the social places they live and are exposed to. And it helps us move from vague questions like, could something in the environment have caused this, to a more structured review of the potential exposures across a child's life course. So we ask about residential history, birth and perinatal factors, diet, air quality, tobacco exposure, chemicals, pesticides, parental occupational exposures, UV, and radiation. We collect this information over time so we can identify patterns and we can build an infrastructure for future research. So the implementation approach is that we are going to be looking for opportunities to administer this environmental health history after diagnosis and during our survivorship visits. And there's going to be comprehensive guidance. Families need accessible evidence-based handouts on air pollution, tobacco smoke, pesticides, household chemicals, radiation, other common exposures. And then third, we're going to give them practical tools. It's not enough to tell families to reduce exposure. We need to give them realistic options. For example, air quality monitors, do-it-yourself HEPA filtration, ventilation strategies, and simple steps that can be adapted to their resources and home environment. So now I want to shift from implementation to real-world clinical examples, as these cases illustrate how environmental health is now being pulled into the conversation at Texas Children's. And again, the point isn't to assign blame or provide certainty when we do not have it. It's offering clarity and actionable guidance. So in this example, we're looking at a child with leukemia, and our environmental health history has prompted us to ask structured questions about whether the child lived near highways, high traffic roads, factories, gas stations, or oil and gas development. And the family reports living near an fracking site in Lufkin, Texas, and they're concerned that the water may be contaminated from nearby operations. And this is especially important for places like Texas, where many children live near industrial activity or oil and gas infrastructure. Again, we're not saying this caused a child's leukemia, but we're recognizing that this context matters, and it's important for counseling and research. So with this family, I reviewed with them some literature in regarding living near oil and gas developments and their risk for child leukemia. This study was done at our institution and looked at over 30,000 children, almost 30,000 children diagnosed with primary cancer in Texas between 1995 and 2017, and found that living within 1,000 meters of an oil or gas well was associated with higher mortality of AML and hepatoblastoma. When I met with this family, I talked to them about a few things. I recommended in-home water quality testing to look for chemicals associated with fracking activity. I recommended home water filtration, and I recommended an indoor air purifier monitor. This next case focuses on tobacco exposure in a leukemia survivor. So our environmental health history asks about maternal and paternal smoking, timing of exposure, secondhand smoke, thirdhand smoke, and whether this exposure continued after diagnosis. So I met with this family and we discussed the harms of exposures on survivors of childhood cancer. This study, done in 2016 by Mateer, shows that children with father who smoke have a higher risk of acute myeloid leukemia. And importantly, this risk increases with how much the father smokes. This family also reported living near a factory. And this is important because of this study in 2024 by George that showed that living in areas with higher air pollution, this was defined as particulate matter consisting of fine particles measuring 2.5 microns or less, decreased the overall survival of childhood cancer survivors. This was even at levels below the current US EPA standards. For survivors who already have an increased risk of cardiopulmonary disease, these environmental exposures may add another layer of vulnerability. So when I met with this family, I told them to improve their filtration systems and to decrease their exposure to outdoor and indoor air pollution, as well as to use indoor air purifiers and monitor. Now, this slide focuses on the growing literature of studies of the importance of environmental exposures in childhood cancer patients and survivors. We are seeing studies examining tobacco smoke, traffic-related air pollution, oil and gas wells, pesticides, and other environmental factors. The evidence is still developing, but the direction is clear. Environmental exposures are relevant to pediatric oncology, and survivorship research needs to include them more systematically. And then our last case. This case really shows how geography and place-based exposures become clinically relevant. This is an 8-year-old patient with a brain tumor who lived at the same zip code during pregnancy, infancy diagnosis, and currently. They lived in the Fifth Ward. This is a historic neighborhood in Houston. And in 2019, health officials identified increased rates of leukemia, and they identified this area as a known cancer cluster. And the main source of contamination was a old Pacific rail yard that used toxic chemicals over time. And these chemicals leaked into the soil and groundwater, and they spread into nearby neighborhoods. So the EPA conducted soil testing in the early 2000s, and they distributed dioxin safety handouts to residents. We discussed this with the family and we provided resources and guidance and practical protective measures for their community. This type of residential continuity allows us to think about cumulative community level based exposures.
Okay, back to me. Um, as mentioned, my role in pediatric oncology primarily, other than covering lots of patients at different stages of illness. My main clinical focus is on patients with cancer predisposition syndrome. So these are patients that have a known predisposition to cancer and an increased risk of developing cancer, but they have not yet developed cancer. And in some situations, like Li-Fraumeni syndrome, it's not a matter of if these children develop cancer in most cases, but when they develop cancer. So these are a very proactive bunch of families typically that I work with, which is a really great opportunity to bring in this type of work. So I typically discuss this with families as part of my social history, kind of talking with families when I meet them about what parents do, getting some occupation, learning a little bit about where they live. And the conversation typically guides us to some topic that I could bring up regarding environmental exposure. And I typically try to take one topic and talk about that with families if it seems like something they would be interested in. I've also made myself available to my colleagues for kind of consults on the fly. If they have a new diagnosis or a patient that's newly diagnosed or on therapy, or somewhere else in their treatment continuum where they might be having questions and the providers need some guidance on how to address those questions with families. So before I dive into my cases, I wanted to remind folks that children are uniquely vulnerable to environmental exposures, which is really the foundation of why this work matters in pediatric oncology. As we all know in pediatrics, they're not small adults. They have higher exposures relative to their body size because they eat more, they drink more, they breathe more per kilo, and their behaviors like hand to mouth activity increases their likelihood of exposure, particularly to dust, which is a magnet for chemicals, soil, and household chemicals. Equally important is their developmental vulnerability. So many organ systems in children are still actively developing, which makes them more sensitive to toxic exposures during many of their critical windows of development. And they have a longer lifetime ahead of them for exposure to translate into disease. Together, these factors underscore why even low-level or seemingly routine exposures may have disproportionate impact in children and why prevention and early risk reduction are so important. This framework, it helps guide our conversations with families and reinforce our role in identifying and mitigating environmental risks whenever possible. And when talking about this with families and why children are more vulnerable, we definitely get a lot of head nods and agreement. Additionally, though, I wanted to point out cancer gets attention, but the everyday impact of these exposures on children's health is actually far broader and better established in conditions like neurodevelopmental effects and learning differences, birth defects, endocrine disruption, such as early puberty, asthma, and other respiratory conditions, even kidney disease. So jumping into some of the cases, this first one was a family that I saw, and they had a child with Li-Fraumeni syndrome, which, like I said, is a very strong cancer predisposition syndrome where it runs autosomal dominant in families. And it's not a matter of when, if, but when in most situations these children are going to develop cancer in their lifetime and often more than one cancer. This family lived in a rural community and discussed that they received their water from a local well. They didn't have any specific environmental concerns that I identified, but it did come up in conversation that this family chose to only use bottled water because they were unsure about the safety of their well water. And they made this decision out of a desire to protect their child, right? So they exclusively drank bottled water just because they heard it was safer. So this was a great opportunity for some education. So while municipal water systems are regulated under the Safe Drinking Water Act from the EPA, and they undergo routine testing for contaminants like microbes, nitrates, heavy metals, private well water is not federally regulated and relies entirely on homeowner oversight. The AAP actually recommends that well water be tested at least annually and more frequently in situations like pregnancy, infancy, or changes in water quality, like if it smells bad or different, since these contaminants can sometimes be present even without obvious signs. So although bottled water can seem like it's a safer alternative, like it did for this family, it's not ideal as a long-term solution. It is regulated differently by the FDA and often lacks consistent testing standards compared to municipal water, and it can contain microplastics or leached chemicals like BPA and phthalates from the packaging. And oftentimes those packaging, those water bottles are being shipped around in hot containers, so even more ripe for leaching of those chemicals into the water. It doesn't contain things like fluoride in some situations and can lack other beneficial minerals, which can bring up dental concerns and other overall health in children. And obviously, not to mention the financial burden and the environmental impact of plastic waste. So what feels like a safer choice might not be the most sustainable or even beneficial one. A more appropriate strategy for this family using well water is testing combined with targeted filtration, while ensuring proper maintenance. Maintenance of these systems is really important. You can have a filter, but if you don't maintain it per the guidelines that is recommended on the packaging, it can get contaminated itself. So it's important in these situations to normalize the concern. You're right to think about water safety in this situation, but really shift it from avoidance to informed management by encouraging testing over substitution in this situation and really providing those actionable steps. Annual well testing, local public health resources, and certified labs that would be appropriate for the families to use in those situations. This next case is a case of a child with a Dicer 1 cancer predisposition syndrome. This patient was, the family was undergoing a home renovation. The patient was actually being seen with grandma, so I didn't have the parents to talk to specifically. But interestingly, they had already relocated the child to grandmother's house because of her asthma. So they understood the importance of air quality and how it could affect her respiratory system and her asthma. This case really reflects a situation where environmental exposures intersects with a known biologic vulnerability, even in the absence of a direct question by the family. So it was a point of conversation that came up, and I asked for the family's approval, essentially, if they were okay with talking about the environmental exposures and a little bit more about air quality. So this child has a Dicer 1 mutation, which carries a recognized pulmonary risk, specifically at a younger age, her age, for risk of pleural pulmonary blastoma. And the context of a home undergoing an active renovation raises a lot of concerns related to air quality in that situation. So renovation environments can introduce airborne particulate matter, dust, VOCs, all of which can impact her underlying pulmonary susceptibilities, PPB, like I mentioned, her asthma. And notably, the family had already made a really thoughtful decision to temporarily relocate her, as I mentioned, because of her asthma, which represents a strong example of really intuitive risk reduction in this situation. And brought up that opportunity to really affirm that decision and expand the conversation a bit broader, like I mentioned. So my role in this situation was really to provide tailored anticipatory guidance by connecting that known genetic risk with modifiable environmental exposures. So we discussed practical strategies to minimize risk during and after renovation, including attention to air quality, avoidance of high exposure periods, like they were already doing. Talked about reintroduction back into the home, mitigation approaches such as choosing lower VOC paints and materials, ensuring adequate ventilation of the home when appropriate, using HEPA filtration and carbon-based filtration for both the particulate matter and the VOCs. And ultimately, this case really highlights how we can personalize that environmental health guidance and reinforce what families are already doing well, while offering concrete steps to further reduce exposure based on their vulnerability. This next case was one of those that actually came up when I was on service and covering a patient that was newly diagnosed with a type of acute leukemia, and dad worked in pest management. And he actually brought this up without me doing much of an environmental history, because I don't typically go too crazy on the new diagnoses. I let them let the dust settle a little bit, but he brought up the concern specifically of did his job cause this child's cancer. And so this represents one of the more emotionally challenging scenarios we encounter, and it's not an uncommon situation where a parent at the time of a new cancer diagnosis asks whether something they did may have caused their child's illness. In this situation, it's essential to emphasize that cancer is multifactorial, and in the vast majority of cases, we can't identify a single cause. While there are studies that have reported association between pesticide exposure and certain childhood cancers, including leukemia, it's critical to recognize that association does not imply causation, and these relationships are complex and often influenced by multiple genetic and environmental factors interplaying. Importantly, this is not information I would introduce in this moment as it risks being misinterpreted as blame. So instead, the priority here is to provide reassurance, reduce guilt, and support the family emotionally. Our role is really to explicitly state that nothing they did or did not do is something we could identify as the cause of their child's cancer. From there, we gently can shift the focus toward what comes next, acknowledging that while we may not have answers about what caused the cancer, we can still support their child's health moving forward. Often this means recognizing that these conversations may need to be revisited over time once that initial intensity of diagnosis has passed and families are in a better space to process that information. We can circle back and discuss practical and balanced strategies for minimizing ongoing exposure and reducing future risk given dad's occupation. So really this case highlights the importance of meeting families where they are emotionally, removing blame, and providing thoughtful strategic guidance that evolves based on the need. And then my last case is a case that came to me from some support staff about a patient that was asking questions about their home and the environment around them. And the reason they were asking those questions is because they had a child that we had followed in our clinic that had recently died. He had a type of leukemia with poor genetic factors and was found to have an underlying TP53 gene mutation, which is Li-Fraumeni syndrome essentially, but it was mosaic in that it wasn't present in every germline cell of his. It was more sporadic. And both parents had that same testing done to see if it came from one of them, and it was negative in both of them. And interestingly, within 8 months, dad had been diagnosed with cancer, and mom had also been diagnosed with cancer, and she had had even more genetic testing to look for genes that can cause the type of cancer that she had, and all of those were negative. So lots of negative genetic testing in this family that was looking for answers in a really tough situation without anything, and hence the email that I received. So they were searching for answers really in a setting of profound and compounding cancer diagnoses. It's essential to acknowledge the weight of that experience and the very natural question of whether there is an unifying environmental cause in this case. And our response really begins with honesty. There are many situations in oncology where we do not identify a single unifying explanation, and that uncertainty can be incredibly difficult for families to sit with. At the same time, we can reframe that conversation away from finding a definitive cause and toward what is within our control, emphasizing that even in the absence of clear answers, there are meaningful ways to reduce risk moving forward. In any case, this was interesting. And so I partnered with our regional PACU, who provided a structured environmental history and individualized recommendations for exposure reduction for this family. And given the clustering of diagnoses, they actually escalated the case to the local health department. And an environmental review is actually underway right now. And I'm not quite sure where things have settled out, if they have just yet. So throughout this process, our role is to guide without assigning blame, to validate uncertainty without amplifying fear, and to connect families with additional expertise and resources, as I did in this situation. It really highlights that even when we don't have clear answers, we can still provide direction, support, and a path forward for families that can be comforting. So across these cases, the specifics are really different, but the underlying work we're doing is pretty consistent. When families are facing uncertainty, like in our well water case, our role is to help clarify what we can and guide them toward meaningful, actionable next steps. When there's known vulnerability, like in the Dicer 1 case, we move a step further. We personalize that guidance and anticipate risk, helping families align their environment with their child's specific needs. In moments of crisis, like a new diagnosis and a parent that's worried about a specific exposure, that priority shifts. There, our role is to reassure and to ground and to remove blame, to support them emotionally, and focus on what matters most in that moment, knowing we can revisit more detailed discussions later. And finally, in situations when there are no clear answers, like the family with multiple cancers and no identifiable cause, we still have an important role. We bring structure to something that feels overwhelming and uncertain, and we empower families with resources, partnerships, and a path forward. So while we may not always be able to define causation, we can consistently provide clarity, personalization, support, and direction. And that ultimately is the role of environmental health and pediatric oncology. We may not always have the answers, but we always have something meaningful that we can offer. What can families do? So I talked about, and Omar talked a lot about different practical steps, but I wanted to circle back to these because I feel like it's something that people always really take home from these conversations. So a key part of this work is making environmental health feel practical and achievable. And these strategies fall into a few core areas, and these are the core areas where the research is strongest for these environmental factors. So for air quality, simple steps like opening windows for ventilation, using air purifiers, like I mentioned, with HEPA filtration for the particulate matter, for the carbon filtration. In addition, if there's VOC concerns in the home, making sure that furnaces and air units have appropriate MERV 13 or higher filters in them, minimizing wood burning, improving kitchen ventilation can significantly reduce what children are breathing every day. So making sure that that hood above the stove actually ventilates out of the house. Using the back burner can also help suck up some of that air so that it doesn't circulate into the kitchen. Opening doors while people are cooking if they have gas burners and are cooking or charring things also is another way to help ventilate that air out. In terms of chemicals and volatile organic chemicals specifically, choosing low VOC or fragrance-free products can be helpful. Reducing dust throughout the house. I mentioned earlier that dust is a magnet for chemicals, and Dr. Metier has done a lot of studies showing us just that. So making sure families are doing some simple things like using a damp microfiber cloth when they're cleaning or dusting, choosing a vacuum that has a HEPA filter, but also making sure that they're switching out that HEPA filter or cleaning that HEPA filter so that it's actually functioning properly. For pesticides, this is a big one. We encourage integrated pest management. So prioritizing prevention first over chemical approaches, and simple habits like removing shoes indoors to avoid bringing outdoor exposures inside can be helpful as well. And then overall, switching to safer cleaning products, looking for that safer seal, that green check, some of those icons that I put there, and really staying informed about environmental health can help families make small, consistent changes over time. The key message is that these practical, often affordable steps can really meaningfully improve the home environment and support children's health. So as we think about integrating environmental health into pediatric oncology, we have to acknowledge some of the limitations and challenges of this work. Many of these conversations happen during times of significant emotional stress, like we mentioned, which can shape how families process information and what they remember. We can take an environmental history. We're often, though, relying on recall, which can be imperfect and influenced by that stress. And we recognize that we're only capturing a piece of a much larger and complex story. There's also ongoing challenges with how we document and structure this information in a way that allows us to learn from it at a broader level and contribute to that evidence base. And we're working on that with a standardized way of asking these questions and documenting that in the chart. So definitely something that's on our radar. And of course, there's limitations in resources and funding that impact our ability to fully evaluate and address environmental concerns. Despite all this, these conversations still matter. Even when the data are incomplete or the answers are uncertain, taking the time to ask, to listen, and to guide families toward practical ways to reduce exposure is meaningful. It's an evolving field, and we continue to build better systems, stronger data, and more collaboration. Our ability to support families is only going to grow. But even now, in its current state, this work has so much value, and it has a place in how we care for children with cancer. So thank you for listening to us. We intentionally left a decent amount of time so that we can open it up to questions. And we look forward to hearing your thoughts and your questions.
Thank you so much. That was an amazing presentation. Every time I hear you guys speak, I always am struck by your just compassionate care as well as just how like really innovative and pioneers you are in this field. So it's really, really exciting to hear you guys talk about this. We have some questions in the chat. Please feel free to drop your questions in the chat. Dr. Wolf said very interesting real life case examples that are not always clear cut in prognosis and clinical outcome. It points to the importance of informed, compassionate counseling. Thank you so much. And then Joel Crawford asked, what about encouraging patients to eat organic foods, especially the Dirty Dozen, per environmental working group recommendations to minimize intake of pesticides? And then also avoiding things like Roundup and other potentially carcinogenic products.
Yeah, I can probably answer that. So as part of some of these educational resources we're giving to our families, that's the Dirty Dozen is actually part of that for the environmental working group. So we give them the updated, it updates yearly, so the families are informed of which produce has the highest amount of pesticides and which ones have the cleanest amount of pesticides. So it's something we work into, and we do give them what are some of the green seal chemicals that are the safest to use around the house. So we do provide them those resources, which we think are excellent.
Yeah, it's an important thing. We didn't dive into that with the pesticides as much. It's like I could have 5 slides after each case about like the epi and the resources and the things we talk to families about. And so I'm glad you brought that up because we didn't specifically mention the organic foods, but it's definitely compelling. And there's research that shows too that children that go on an organic diet and they check their urine for pesticides, like it actually goes pretty low to null and while they're on an organic diet. And then when they reintroduce non-organic foods, those levels of pesticides increase. And like I said, some families, it's really kind of feeling out where they are, right? Because some families, organic is not even an option, which is where the Dirty Dozen and Clean 15 is really a nice kind of spot to land on families, for some families in guiding them on the best approaches for that. And I think I also get a lot of head nods and agreement from family when we talk about pest management and glyphosate, like you mentioned, for killing weeds. You know, people, they see weeds and they want them gone quickly, and spraying things that are going to get them right away are really great, but you're also spraying that in the air where your kids are playing outside while you're working, and what seems like something that's going to be quick and effective might be more harmful. And so talking through other strategies there, and with the pest management, you know, we all have those friendly neighborhood pest guys that knock on our door and want to sell us the plans. And, you know, the more people in the neighborhood that sign up for this plan, the cheaper your monthly bill is going to be. And we're going to come in like every couple months. We're going to spray your house. We're going to spray around the outside. And we don't have to say yes to that. And so that's a great kind of lead into talking about that integrated pest management. And we have some good resources for families for that as well.
Thanks. Those are great. Rachel Schramm had a question about just curious how you explain the complexity of cancer causes to people. Great presentation, learned a lot.
Yeah, and I think that's such a super important question. So the way I usually explain it is that cancer is rarely caused by one single thing. It usually develops through a combination of factors, like changes in our cells, the immune system, developmental factors, timing of exposures, and these environmental influences we've talked about. And so for children, this is especially hard because parents just want to know why, and we and we can't give that a single clear answer. So I try to separate cause from contribution. And so that's something I try to focus on when I talk to these families in these consults. And then, as Nikki talked about, kind of the overarching thing is when we communicate with these families, is that we really emphasize this is not about blame. Families didn't cause their child's cancer, but really our goal and the goal of this program is to better understand the risk and reduce exposures where we can and create healthier environments for children moving forward.
It is so complex and it's hard, and families want answers. And I feel like innately, as pediatric oncologists, especially, like we love to spend time with families and we love to talk. And I know I personally have to like remind myself not to talk too much, because it's just I don't want to send these families down a rabbit hole. I also mentioned how I like to pick one thing to talk about in my conversations with them, and Omar does similar with his strategy and using the environmental health history and picking something that is striking on their intake, because the last thing you want is for them to walk out and be like, okay, I need to start buying organic. I need to throw out all my plastic. I need to buy air purifiers for each room. Like that is so much more stressful and financially burdensome than picking one thing that you can work on to change. And you can acknowledge there's lots of things we can do, but we can't do everything at once. And let's start on this one thing, and we'll circle back the next time we meet at our next clinic visit. And maybe you're still working on that one thing, and we can talk about it again and see how to get back into a rhythm and making better choices on that one thing. So um, sometimes it's right, two steps forward, one step back, and that's important to remember too in these conversations.
Yeah, thank you so much for those answers. I think that's just shows your expertise on this topic, and it is really, really challenging. Dr. Joel Dunnington was questioning about your advice around smoking, parental smoking and vaping.
Don't do it.
Do you guys mention that as well during your visits?
Yeah, so that was that was one of the cases I presented was it's a common thing. Patients who are either before treatment, during treatment, and after treatment, they're being exposed to firsthand, secondhand, thirdhand smoke. So that's kind of one of our biggest components of this environmental health history we made. And that is we do spend a lot of time counseling patients on the importance of that. And we also presented a study that showed that it does decrease survival as well. So,
I think an interesting thing too, Omar, I don't know if you remember this, but I remember Dr. Weimel's showing some work with methylation on smoking and kind of the underlying epi about it. And it's actually there's some reversibility in that. So you can actually make meaningful changes by reducing that exposure. Because of the methylation profiles of some of these patients. And so I feel like it also reminds me too about just general pediatrics, when I remember one pediatrician I worked with talking about like the smoke coat, if you're going to go outside in your garage and smoke, you put this coat on and then you take it off and you try to minimize that exposure to your child. While obviously we would want them not to do it, in a stressful situation like a new cancer diagnosis and a habit that someone already has, that might not be something that is in the cards at the moment, but definitely something that can be worked on. So really talking about those ways to minimize that exposure to the child, direct firsthand smoke, absolutely, and then other ways to minimize that secondhand or thirdhand smoke, and sometimes it's easy wins like, okay, like do you smoke in the car? Do you smoke in the home? And interestingly, wearing my informatics hat, this is like the one environmental history thing that is discreetly documented in the chart, usually like 15 times. For some reason, it like pulls into the chart, but like nothing else from an environmental standpoint gets documented in the chart in a structured way. So this is something in my area of interest with getting some of these questions that we're asking into the chart in a more structured way so that we have that face up and we can have consistent messages across provider care teams that are seeing these families so that folks can see kind of what's going on in the environment, not just us. And then obviously using that data long term to answer research questions would be really useful to have that structured data.
Oh my gosh, that would be a dream. We could
We'll
do
get
so much more with that. Suzanne Condon was asking on the environmental history intake that was created, do you guys include drinking water in the nutrition section? Just curious, given that drinking water exposures seem to have widespread concern.
Yeah, actually, and this is something that gets brought up so much. So, hi, Susan. Good to hear from you again. And so, under chemicals and pesticides, we have definitely dedicated a portion that talks about drinking water source. So we ask about, what was your primary source of your family's drinking water before and after diagnosis? So we ask, did they have freestanding filtered water, or refrigerated filtered water, bottled water, unfiltered well water, unfiltered tap. And then we do ask about water quality testing. So, was your household ever tested for contaminants before and after diagnosis? And if yes, what was it tested positive for? Bacteria, pesticides, lead, other chemicals. I know PFAS is now starting to get brought up with some of these families. So we do ask about that, and then we do have some counseling regarding that topic because it is such an important one.
I think we have time for maybe one more question. And I acknowledge that we didn't get to everybody in the chat, so we can also send you those and maybe we can offline do more questions. But I think this is a great one to end on. So Angela Ritchie asked for educational resources for the families. Are those created locally by your teams, and are there any specific materials that are broadly available? And so I think this is a great question to end with.
Yeah, because we would really be remiss if we didn't. Like this is not just Omar and I, as we mentioned at the beginning. There's a lot of folks from our group, and others that are doing really important work in this space. And I feel like the more we hear about them, the more we connect with them, and just trying to make those collaborations. But the PACU in and of itself has a lot of amazing resources, and each PACU has its own website with its own resources, and then the National PACU site has a specific subset for the childhood cancer in the environment program, and that national PACU site is a newer site. A lot of these materials for the childhood cancer in the environment program were actually housed under the Western States PACU until recently, so it's nice to have a dedicated space, but a lot of those resources have been kind of revamped to have a little bit of that childhood cancer focus on them. And so it's a lot of kind of rinse and repeat and taking materials and putting them in different formats depending on what the audience is. So that PACU website is a really great starting place. And that's where and I think Omar too, guides a lot of our families to. There's some short videos on there that are good for both provider facing material and patient facing material. Um,
Yeah.
but yes, a lot of folks that there's a lot of resources out there, and I feel
Yeah.
like Vicky especially will say too, like they probably have a resource for something when we talk about needing one, and it's just a matter of kind of pulling it into the format that we need for the specific education we're trying to give.
Yeah, and Hannah's been really instrumental in helping us make some of these resources. So focusing on just the families and just the clinicians, and then communication strategies of how to talk about these environmental risks. And Whitney just redid the childhood cancer environment website, so to kind of make this a little easier to navigate. So that's definitely now becoming the central hub, I think, of all the resources.
Yes, and it's important to know where those are. And I think the more you familiarize yourself with them, the more comfortable you're going to feel um, engaging with families in these conversations. And it's taken me a while to get comfortable, and there's definitely still questions that are not super comfortable to answer. But what I remind myself is that they're going to find the answer somewhere, and they're going to keep asking that question until they get someone to give them maybe not necessarily the answer that they want, but at least an answer that is comforting to them and helps satisfy that question. So that's what I remind myself is that, these parents are talking about these things. They're coming up in social media queries. They're asking their chat GPT. So I want to I want to feel like someone that families feel comfortable talking to and asking those hard questions. And I want to respond in a way that makes them come back and tell their friends to come back because I want them to get that information from a reliable source. And that's really important to me.
Yeah, especially with the advent of all the of all the chat bots and everything like that. I feel like this information, whether correct or incorrect, is more readily available to them. And so yeah, having that trusted resource is really, really important. Okay, I think we are almost at time, so I just wanted to um, put reshare my slides. Um, And just thank you guys so much for your work and your ongoing work and just your dedication to this topic. It's so, so important and it's very evident. So thank you for your work and your interest in presenting to us today. Like I mentioned, this is our last webinar of the academic year, so we will start back up around September. So if anybody has any topics of interest that they would like to hear from us next year, please let me know. Otherwise, if you have any speakers of interest, please also let me know because we're always looking to make this webinar as useful for the audience as possible. And I'm just showing right now the slide for our newsletter. Please feel free to sign up for it if you haven't already. And then this is our survey. So we would love to hear from you. Like I said, we're always trying to improve this webinar. And so we love and really appreciate and acknowledge and really use your feedback to improve it. So I really appreciate that. I'm going to leave this up for the next 2 minutes until we're at 3 o'clock. But thank you again so much for your work and for your presentation today.
You're so welcome, and feel free to email me with any other questions anyone has. I know there's some things we couldn't get to in the chat, but we can go back and answer them for you. But thanks for tuning in today. Really appreciate it.